So recall that last year when I came to you, we talked about the different locations to point the probe, and the one way is here against the parasternal long axis. This is where, as its name suggests, parasternal, para means next to, sternum. You place it right along the edge of the sternum and you aim the indicator down towards the patient's left, somewhere between if their arm was at their side, it would be their left elbow or their left hip, in this kind of direction this way. And then the apical four-chamber view, where we place the probe right on top of the point of maximal impulse, or PMI, and then we shoot the sound right down through the apex into the heart with the indicator towards the patient's right. We're not going to be talking about the subxiphoid view in this talk. We will in the future, but not for this specific talk. Now, in the parasternal long axis, you're going to place the probe along its longest axis, okay? Notice I'm not saying, show me a sagittal view of the heart or a transverse view of the heart. I don't say that because the heart runs in an oblique plane. It runs in a sort of a cattywampus plane across the body. So that's why we describe it in terms of its axis rather than its plane. We say parasternal long axis, or we'll say parasternal short axis sometimes if we turn it the other way. But it looks like this. We have the indicator down towards the patient's left elbow if their arm is at their side. That's probably the best way to describe it. And what you see when you do that is very superficially here, very anteriorly, we see the right ventricle. Okay, so the right ventricle, it's amazing how close it is to the skin line, and how that's a little chink in our armor as human beings, where if we had somebody stab us there, or maybe it was a stingray that we're swimming with could get us there in the in that sort of parasternal fourth, fifth intercostal space, that's where you put the probe in order to see the heart, because it comes so close to the chest wall. In this view, in this long axis, with a three-chambered view, we see the right ventricle up here anteriorly, then we see the left ventricle down here, and the left atrium is over here. So the blood's coming from this left atrium, it's going through the mitral valve into the left ventricle. As the left ventricle squeezes, it goes out the left ventricular outflow tract, and then to the aorta, and then to the rest of the body. Now, it looks a little something like this during systole and diastole. Here it is again, the left atrium, our left ventricle, and then our aortic outflow tract. And you can make out this mitral valve. It's a bicuspid valve. We see the anterior leaflet right here. We can see as it makes its way up towards the interventricular septum, which is right here. And ideally, you should see that anterior septal leaflet of the mitral valve come up and smack that interventricular septum. And here's that posterior leaflet down here. So during diastole, when the heart is sucking the blood out of that left atrium into the left ventricle, as it expands out like that, a good contracting left ventricle, a good functioning left ventricle, will get that mitral valve to open up nice and wide. And that's one of the normal findings we see. The other thing we look for in normal contractility is this interventricular septum right here. We like to see that come towards that posterior wall, and vice versa. We like to see these two things squeeze together, and that's another sign that there's good contractility. And then finally, this is the left ventricular outflow tract here. I'm going to go ahead and pause it right there. And this is end systole. We can see that the heart is all nice and contracted down with the septum towards the posterior wall. End systole, these valve leaflets fly open, and this distance right here is called LVOT, or left ventricular outflow tract, and that becomes a critical measurement when we want to measure the cardiac output. And this is what it looks like in all its glory, a nice normal-looking parasternal long axis. And I say normal because when I look at this, I'm looking for really two main things. I'm looking for that this mitral valve comes up and smacks that septum, and then number two, that this posterior wall and this interventricular septum make their way towards each other. And indeed, they are doing that in this view. And so what I do clinically is, if I have a patient who's got hypotension, okay, I am trying to resuscitate them, and I break hypotensive patients down into, do I give them fluids? So if a person comes in my ER, their blood pressure is 70/40, how do I get their blood pressure back up? I can give them fluids. That's kind of my knee-jerk response. And if I saw a normal functioning left ventricle like this, yeah, I could safely give this person fluids. And that would probably fix their hypotension. But instead, if I saw a weakly functioning left ventricle, if I gave that person fluids, well, then I could be in trouble, because that fluid, if that heart is too weakly functioning, it can't handle that fluid that I'm giving it, and the fluid starts to back up in the lungs, and the patient can go into pulmonary edema with congestive heart failure, and that's what that means. And so And those patients, you got to be very gingerly with the fluids, and you want to give them another type of medication to help their heart contract better, an inotropic medication. One example is dobutamine. Now, this is just a sort of schematic diagram laid over the parasternal long axis to show you kind of where the chambers are, where the leaflets are, and sort of the idea there. Now, we're going to look at these next few hearts, and I want you to tell me, do I give this patient fluids or inotropic medicine when I see this heart? Right off the bat, you guessed it, inotropic medicine. How do I know that? Well, I'm going to first look over there at that mitral valve. Is it smacking the septum? Nope. And then I'm going to come over here to that posterior wall and the interventricular septum. Are those two things coming together? Nope. So this person, if I gave them fluids, it could back up in their lungs, and I have to be very careful here. Because, you know, when the nurse comes to you and says, hey, this patient's hypotensive, we got to resuscitate this guy, how much fluid should I give him? That's their first question to you. So you just got to be very careful there that you don't just start dumping fluids into a heart that looks like this. That's why anybody's hypotensive, I immediately go to the bedside and I take a look at their heart, and then I make a decision about whether or not to give fluids at that point. What do you think about this heart right here? First question that comes to my mind, I look at this heart, I look down at the patient, and I'm like, are they dead? Does this patient have a pulse? Because this heart is really not looking good, right? So first of all, we got that mitral valve. I mean, the mitral valve is just sort of camping out right here, not doing hardly anything at all. Certainly, it's just almost just kind of fluttering along there, not really making any decent headway at all towards the septum. Then we look. This is the chamber size of the left ventricle here, and we see that interventricular septum. We see that posterior wall, not really squeezing together very much. In fact, not really moving at all. Here's another thing I'm noticing. The right ventricle is up here. It's actually larger than the left ventricle, and in certain settings, this is a problem, because when we see somebody with a large right ventricle, normally the right ventricle is only 2/3 the size of the left ventricle. When someone gets a right ventricle that gets as big or even bigger, like this case, than the left ventricle, that's a sign of right ventricular strain. What would cause that? The right ventricle is trying to pump blood to what organ? The lungs, right? So the blood's trying to get out to the lungs. If the right ventricle is straining so hard to push that blood out to the lungs because something in the lungs is not letting it get there, like a blood clot, pulmonary embolism, if the blood can't get out there, the right ventricle just starts to get bigger and bigger. We call that RV strain. And RV strain, one of the first life-threatening causes that comes to mind, is something I can treat with thrombolytic therapy in the setting of hypotension. In the setting of shock, thrombolytics are indicated. And on this patient right here, we did give them thrombolytic therapy, and they actually did have a blood clot in their lung, and they survived. Another thing that can cause RV strain is pulmonary hypertension. The blood's not getting to the lungs as well as it should because of some narrowing there or some increased pressures in the pulmonary system, and it causes the blood to back up in that right heart, and you get RV strain. Do you have a question?
Yeah, does the ratio would change depending on the cross-section that you're taking, or potentially maybe the angles? How do you...
So that's a good question. So how do we know that this is really, I mean, we've got this long axis through the heart. If I fan the sound from one side to the other side through this cylinderish, cone-ish thing, maybe I'm just shortening my axis, my view of it, right? Well, if I can see the mitral valve on the screen, I'm pretty much at the midpoint of this person's heart. So I see the mitral valve on the screen. It's a good question. I'm not off to one side or the other. I'm straight dead down the exact, sagittal axis, not to use the word sagittal, long axis, sorry, of this heart. So this patient's got had very poor LV function, but certainly with when we were able to give this patient some thrombolytics, that cleared up that blood clot, blood got back to the lungs, and this patient actually had a pretty decent outcome. What about this one here? Fluids or inotropic therapy? If their blood pressure was 70, I'm looking at that mitral valve, I'm saying, yep, coming up and smacking that septum right there. See that? Right there, actually, yeah. And you could do that in your machine. You can freeze the machine, and you can back it up or go forward with it. You're going to do that today quite a bit. So there's that mitral valve smacking that septum. Now we come over and look at that interventricular septum and its movement towards that left ventricle. Let's call this right here end systole. How do I know that is end systole? Well, the posterior wall and the interventricular septum are close to each other right there, and this aortic outflow tract, that's open. This is the one leaflet of this aortic valve. It's a tricuspid valve. We don't see all the leaflets here. There's one leaflet. We can see it's clearly open, and I'm sort of hallucinating a little bit. Maybe that posterior leaflet down here is also open, and the blood's coming out during systole. And this is that LVOT that you're going to measure as one measurement when we move to the hemodynamics part of things. So this person's actually got pretty good contractility there, and I would say this person, if they were hypotensive, I would open up the fluids on this patient to resuscitate them because of the normal RV function. And by the way, I kind of paused it at the end of systole and the end of diastole. The end of diastole is right here, somewhere around here, okay? See how the chamber size is the largest there? So one thing you can do, if you want to take the time to do it, you can actually measure the left ventricle at the end of diastole, and you can drop some calipers that we call discs through there. There's several ways to do it, but you can imagine you could trace the area of the left ventricle cone at the end of diastole, do the same thing at the end of systole, and the machine will calculate the ejection fraction as an actual number. The only downside to that is that because we look at these hearts in 2 dimensions, they don't always have the most accurate numbers, and it takes time to do that. It takes, some really futzing around with the machine and dropping calipers and getting all those numbers on there and cranking out the software. Personally, I just look at that heart and decide from a qualitative perspective if I'm going to go with fluids or inotropic therapy. And that's what I want you guys to remember. Quantitatively, I think the cardiac output stuff we're about to do, very useful. Ejection fractions, I don't know. I just like to look at these hearts and decide what I'm going to do next. How about this one here? Medications or fluids? Medications, exactly right. See that mitral valve there? Not really doing much towards the septum. And we come back there, we look at that septum and that posterior wall, not doing a lot for me either. Not a lot of delta in that chamber size between end systole and end diastole. You guys think about this. Medications or fluids? Medications, very good. Excellent. Any questions before I leave kinesis and move on to Doppler color? Okay. Now, this is a slide that you saw last week, and hopefully you remember it. This is where we're talking about in the physics lecture that when you work with color flow Doppler, red is flow towards the transducer, and blue is flow away from the transducer. Okay? This is just demonstrating an aortic, abdominal aortic aneurysm and some sort of turbulent flow rolling all around in there. So it's just to show you the red and the blue. But really, it's the scale that I want you to pay attention to. Red is flow towards the probe. Blue is flow away from the probe. Yes?
Can you just, to get this in my head, the top of the screen would be the transducer?
Correct. Exactly right. This is the skin line of the transducer, the footprint of the transducer right there. And the way we activate this flow, we come down here after we hit mode. Here's the different modes. Well, there's 2D, which is just straight up brightness mode. There's color, which is what we're seeing here. So you're going to activate that color, and then you're going to see the this color box pop up on the screen, and you're going to place that over the valve. Now, before we do that, I just want to give you a quick little video reminder about what mitral valve regurgitation is.
A healthy mitral valve keeps your blood moving in the right direction. A leaky valve doesn't close the way it should, allowing some blood to flow backwards. Your heart becomes less efficient, and if left untreated, a leaky valve could lead to heart failure.
So we see this, this is the parasternal long axis, and we see this color box placed, or sampling box placed over the mitral valve. And here, the mitral valve is actually closed, and there's a red jet squirting backwards in this direction, which tells us that there's some mitral valve regurgitation going on here. Now, one of the problems with measuring color flow across the mitral valve in the parasternal long axis is that this is not the best spot to do it. It's better to do it in the apical fourth chamber, which I'll get to in a minute. The reason the parasternal long is not the best place to do this is because the mitral valve is really perpendicular at this location to the transducer. And remember from the physics thing last week that cosine of theta is in the numerator of the Doppler equation. And so whenever the red blood cells are coming along, when they get right underneath the probe or 90 degrees to the probe, you get cosine of 90 in the numerator. That's 0 in the numerator, and you get loss of the Doppler signal. You're going to hear me come back to that over and over again. But that's why you could drop the gate there, and they do it right here, and it shows some flow going the wrong direction across that valve. But what they've done is they've actually steered that gate just slightly off 90 degrees. And that's a little bit of a fancy adjustment you could do on the machine, but we're going to learn that throughout this year. Now we're going to switch to the apical four-chamber view. This is probably the hardest view of the heart to get, the most challenging, requires a lot of patient positioning. It's particularly difficult in women with large breasts because you got to move their breast out of the way to get to this little view here. So this is one you're going to struggle with to obtain, but it's the one that gives you the most bang for your buck. So you're going to place that transducer just inferior to where sort of the nipple line is and lateral in that area down there by the nipple. And you're going to have the indicator to the patient's right. And basically, because you're placing the transducer right on the patient's PMI, remember during physical exam skills, you'd roll the patient left lateral decubitus, you could wedge a pillow under the right shoulder. That brings the heart to the chest wall. That's exactly what you're going to do here every time you do an apical four-chamber view. Okay? You're going to roll the patient left lateral decubitus, stick a pillow under the right shoulder, and then you're going to put the probe right on their PMI. Okay? And what you're going to see when you do that is at the very top of the screen, the skin line, with the probe's footprints on the skin line, you're going to see the apex. And then the sound is shooting straight down the barrel of the gun that is the heart. Okay? And it's a great way to see that the RV is about 2/3 the size of the LV. It's a nice way to kind of gauge chamber size, the overall function of the heart, the atria, the valves. It's a cool view. And this is a schematic of that apical four-chamber view. And just think about our probe being right up here, and that sector of sound is coming out like this, apex of the heart being here. And if we were to put color here, here's the left atrium, here's the left ventricle, right atrium. Remember the indicator is to the patient's right, which makes this the right side of the heart. Left atrium, the blood is flowing from the left atrium into the left ventricle. And if we were to put that color flow signal along here, well, red would be flowing towards the probe, and blue would be flowing away from the probe. That's the idea. So keep that in mind as we go through this stuff. By the way, the aortic valve is like snudged right up in here. We're going to get to that in a minute, but that's where the aortic valve is. So once it's coming out of this, during systole, it's being pumped out of this LV, assuming there's not much mitral valve regurgitation. In other words, the blood is not going this way, but it's going right down into this little area that's off out of the plane of view. It's a little bit more anterior out of the plane of view, and that's where the aortic valve is. Fourth view, you want to have the indicator here towards the patient's right again. You're sort of right underneath that left nipple, aiming towards the spine. And that view there will get you the heart on the screen to stand straight up with the septum standing top to bottom. That's the septum there. This is the left ventricle, right. So this is what it looks like when this is sort of an average view here. I wouldn't say it's extra pretty. I would say it's not too ugly or fuzzy. It's probably about the average view that you see. Because remember, there's so much lung around all this stuff that and lung air is the enemy of ultrasound. You get some scatter there. So that's why sometimes they don't look that crisp. And the larger that the lung fields these patients have, so the patients who have COPD or expanded lung fields, you're going to struggle extra hard trying to get these views. Okay? In the models upstairs, I'd say pretty much all of them have pretty decent apical four chambers. Last Tuesday, we had one person really struggled to get her apical four, but everybody else upstairs today seems to be pretty decent at that. Notice once in a while we see that aortic valve pop in there. See that little spot? We're going to come back to that. Let's go ahead and throw some color across that mitral valve. Now, during systole, red is flow away from the probe, red is flow, blue away, red towards. I mixed that up. That's one way to remember it. BART, blue away, red towards. During systole, we don't expect to see blood being squirting away from the probe back into the left atrium. So this blue jet that we see here coming in the back that left atrium and smacking into the far wall of that left atrium, that's a good amount of this would be somewhere around moderate to severe mitral valve regurgitation, because we see how that during systole we shouldn't see that blue jet slamming back into that left atrium. Make sense? All right. Now, keep coming back to this, but this is the aortic valve in here. And during systole, the blood really should be going here and not back through the mitral valve. Let's talk now more about this aortic valve. Actually, it's something called the apical 5-chamber view, or A5C, the 5th chamber being that aortic valve. Recall that that aortic valve is a little bit more anterior, so what we need to do is, once we're in the apical 4, we simply fan the probe a little bit more anteriorly and kind of tilt it up a little bit, and we should see that that aortic valve jumps in the middle of the screen. The tricuspid valve and the right atrium kind of go out of the imaging plane while the aorta maintains itself right there in the center of the screen. Sometimes it's hard to do in females when you're trying to keep them covered up, but you need to go one intercostal space higher or more superior and slightly more lateral to get better alignment with that ultrasound beam. This is all stuff in hands-on that you're going to pick up over time practicing with this. I just wanted to briefly describe it before we get to hands-on. This is a still image of that aortic valve. This is the aortic 5th chamber, if you will, apical 5th chamber. Here's the LV, here's the RV. We see the apical 5th chamber there. This is the RA, kind of out of the plane. We don't even see the tricuspid valve anymore because we're so anterior. This is the LA with its mitral valve. We can still make that out. This is what it looks like when we have it really nice. Apical 5th chamber. There's the aortic valve right there. See that? Where my arrow is? I'll get it out of the way. And over here, BART, blue away, red towards. Okay? We've got the transducer up here along that apex. And during systole, we expect to see blue away right into the aortic valve. That's what we're expecting to see. That's normal because the blood's going through that aortic valve. If we get a red towards, well, then the blood is regurgitating back across that aortic valve and back into the left ventricle. So that's why there's a little aortic regurgitation coming out of the aortic valve just right here. That's what that red is, red towards. So this person has some aortic regurgitation. Now, that left ventricular outflow tract seen in that apical 5-chamber view, this is just a schematic of it. This is where you're going to be dropping that Doppler gate right through here. And somewhere along that gate, you'll see that little TIE fighter looking thing. That's going to be just somewhere right on the edge of this aortic valve, just right along here. That's where we're going to be dropping that Doppler little TIE fighter, in this general vicinity in here. And that will set us up to measure the cardiac output. Let me show what I mean. So to measure the cardiac output, the first thing you do is you measure the diameter of the left ventricular outflow tract. And you can see that in the parasternal long axis. So first thing you do is you go back to parasternal long. Remember that? That's the RV up here, the LV over here, the LA is here, mitral valve is right here, and then the blood comes in this LV and it gets pumped out this aortic outflow tract. And actually right now I could tell that this aortic valve, when they come together, they have that little white line at the tip of my arrow. You can see that little white line. That's the leaflets that came together. And so that's during diastole, the heart's filling, those leaflets are together. Now, this is just a frozen and zoomed in version of that exact same valve. The leaflets are together. So in that frozen state, you can then take the dial, bottom left-hand button, and you can rotate that dial counterclockwise, and you'll back up to where end systole was. And those valve leaflets, you'll watch them just kind of march right open. And once they're open at their maximal point, you can put this, you can take a measurement here using the calculations functions between those two leaflets, and that's your LVOT diameter, your left ventricular outflow tract diameter. And that's going to be an important part of this whole cardiac output. So what the machine does is you lock in that value of the machine immediately squares that value, times it by pi, divided by 4 to give you the LVOT area. So it takes the diameter, converts it into the area, and then the next thing you're going to do is measure the velocity time integral across that aortic valve. What does that mean? Here's what this means. You take that pulse wave Doppler, that TIE fighter thing, and you drop it right across that aortic valve right here in the apical fifth chamber. And then you activate the actual waveform, and this is what it gives you here. The x-axis is time, the y-axis is velocity, and so this little envelope right over here, this is the velocity time integral, tells you that value, the velocity time integral of this envelope, in combination with the LVOT area, will give you, times heart rate, will give you cardiac output. In the old days, we had to take this little green thing right here, we actually had to freeze the screen and then actually trace this out by hand. Okay? That's what we used to do. Well, nowadays, as of 2 months ago, the machine does it automatically. And so that's really, it's actually why I'm teaching it to you, because it's so convenient now to do this. It's just one huge less step to deal with. So to summarize, we got the LVOT diameter, we measured that ourselves, we gave that to the machine, and then the machine squared that times by pi divided by 4, and then it takes that and multiplies it by this term right here, the LVOT velocity time integral, that value, and that gives us stroke volume. And by the way, on the screen, since it's watching this, the pulsations of the heart, it knows what the heart rate is. So it takes that stroke volume, multiplies it by the heart rate that it's watching, and gives you cardiac output.